Good morning, everyone. It gives me great pleasure to introduce our speaker for this morning, Dr. Gregory Prokopovics. Dr. Prokopovics is from Johns Hopkins. He's an assistant professor of medicine over there, and he did his undergraduate as well as medical school and MPH training from University of Michigan at Ann Arbor, and his residency in internal medicine at Johns Hopkins Hospital. He subsequently decided to do a master's in computer sciences from Johns Hopkins Whitting School of Engineering, and has been actively engaged with the Johns Hopkins Bloomberg School of Public Health, and his interests lie in evidence-based medicine as well as pharmacoepidemiology, and especially in hypertension, and he's going to be discussing providing us a hypertension update today. So welcome, Dr. Prokopovics, and we look forward to this talk.
Thank you very much for inviting me, and pleasure to be here. I feel kind of tall on this dais. Okay, I might just step off that. But so yes, I'm Greg Prokopovics. I'm a general internist. I have a primary care practice, and also hypertension is sort of a hobby of mine, and I direct the Clinical Hypertension Center at Hopkins, which really consists of difficult hypertension cases in the outpatient arena. So my focus is really almost exclusively outpatient, and my talk will be about outpatient hypertension. I hope to have left enough time for questions at the end, but please feel free during the talk to raise your hand if something strikes you. I'm particularly interested in practical questions you might have encountered with your patients, and I'll be happy to give my opinion on how I would handle a situation. I'm going to try to cover three topics today that I think have undergone some change or are in flux currently that I think you ought to be aware of. The first one is about measuring blood pressure, which is an old and a new topic. The second one is about the status of current hypertension guidelines. And then the third is a practical, short few slides on things you can try in your difficult hypertension patients to get them under control. So to start with blood pressure measurement, you might wonder why we are talking about this. It's been in use for over 100 years, but there's still not agreement about how best to do it, and it's a topic of much discussion at hypertension conferences. There have been a number of technical advances in the area, and as you know, home blood pressure monitoring is becoming commonplace now. The monitors are getting cheap enough and easy enough to use that they're really becoming widespread, and I think that's really going to change in the last 5 or 10 years. So in contrast to 50 years ago, where pretty much just doctors and nurses and allied health professionals measured blood pressure, now pretty much everyone is getting into the act, and we as physicians or clinicians end up on the receiving end of a lot of that data, and sometimes are not sure exactly what to do with it. So I'll try to get at that a little bit. In addition, there's increasing scrutiny on our numbers. So at Hopkins, and I'm sure here and elsewhere, people are looking at the numbers you record in the chart, the blood pressure numbers, and grading you on whether they meet certain criteria. So the way these numbers are measured has a big bearing on how easily you can adhere to various guidelines. Just a little bit of historical context. These are the founding fathers of blood pressure measurement. The guy on the left is an Italian, Riva Rocci, who came up with the idea of wrapping the inflatable bladder around the arm, and he was initially doing this using a palpation method. So I don't know if you've ever taken palpated blood pressure. You can get only the systolic from palpated blood pressure. Korotkov, a Russian, came up with the idea of listening for the sounds, and thereby enabled us to measure both systolic and diastolic blood pressure. And this was at the beginning of the 20th century. And so their method really has been in use almost unchanged for over 100 years. Not long after this technology was developed, clinicians started getting into the act. This is from a book that Theodore Janeway, who's later went to Hopkins, he wrote in 1904. And the reason I show this is because almost as soon as we became aware of measuring blood pressure, people started to notice that there's a tremendous amount of variability in blood pressure. And this is a lesson that keeps being learned and forgotten over and over again. And we still have some difficulty knowing how to deal with this issue. So here he was playing around with a sphygmomanometer and noticed that he was sitting down, his blood pressure was 135/100. And then after running up 3 flights of stairs and sitting down, it was 175 over 120. And I think about what happens in our clinic every day, where my patients are running to get to my clinic visit, and then as soon as they register and get to the back area, the medical assistant sits them down and measures their blood pressure, and it's 175 over 120, and I get a little pink flag on the measurement. And later it comes down as they rest, but I think we need to be aware of the fact that how we take the measurement has a big effect on that. Subsequently, the Framingham studies were done, and that's where we gathered most of the initial data that blood pressure is bad for you, and started to routinely incorporate this into medical practice. And so we had the scenario where doctors would check blood pressure measurements at clinic visits, maybe once or twice a year perhaps, in this type of scenario. And that paradigm, as it were, has gone on for many years until fairly recently. As I mentioned, there's a lot of variations. So these are studies done in the 1960s, but as you can see in this study, they took 2 subjects and just looked at blood pressure, systolic blood pressure readings from one visit to the next across 20 minutes, and there's wide variability. And this presents a clinician with a problem. What do you do about this? We have a similar situation in blood glucose. If you check blood glucoses, they bounce around, but in diabetes, we have an A1C that averages everything else out nicely for us. We don't really have a hemoglobin A1C, a blood pressure, so we have to figure out how we're going to integrate this variable information. Across the course of a day, blood pressure can vary a lot with daily activity. It can go up at meetings, down with sleep. Probably if you're sleeping at a meeting, it's somewhere in between. So when patients take blood pressure cuffs home with them, we see this sort of stuff reflected. This was just kind of an interesting study from 1969. This young man was a volunteer for an early ambulatory blood pressure monitor, and some of the first ones were actually intra-arterial. So this guy had an intra-arterial catheter in and went for 24 hours recording his blood pressure. And I show this because blood pressure spikes, which we all encounter in clinical practice with home blood pressure monitoring, are actually a normal part of human physiology. So this is the reading they got from this young man's blood pressure over a 24-hour period, and you can see certain spikes. Let's see. I'm not getting the animations coming in. Is there a way to do that? Do you know? If not, I'll just point it out. We can probably just dispense with it because I don't think it's going to work. Oops. This spike here was from a painful stimulus, unspecified. This spike here was actually intercourse, and I've got to give this guy credit for having intercourse with an arterial line in place. But you can see that the blood pressure jumped up good 50 points. Now, patients sometimes, when their blood pressure jumps up 50 points, will absolutely panic, and they think they're going to immediately stroke out. And sometimes clinicians will tell them, you better get to the ER right away. And I think one of the lessons we're learning is you really probably don't need to do that. It doesn't really accomplish much for the patient. Not surprisingly, after intercourse, there was a period of sleep here, and the blood pressure dropped a lot, and then an early morning elevation in blood pressure, which is what we expect to see. I think this is kind of an interesting study. This was done in some healthy young men, and they again put an intra-arterial catheter, and you can see their blood pressure starts off at about 120 over 80. Then they have them do squats with the catheter in, and look what happens to their blood pressure as they do each one. When they're really pushing, maxing out, 345 over 245. So, and there are other studies that show equal numbers in the 400s in weightlifters. And I show this because, again, I think we have to have a sense of perspective about the numbers that we get back from ambulatory blood pressure monitoring and from home blood pressure monitoring. When people talk about the relationship between blood pressure and stroke, there's no question that there's a clear relationship, but it's not a simple matter of the pressure building up until the artery ruptures. In fact, most of the strokes caused by blood pressure are thrombotic strokes. So it's really, in most cases anyway, a long-term degeneration of the arteries that leads to stroke and blood pressure, and not as simple, like an overfilled water balloon popping at a certain level. Our presence as physicians and nurses has an impact on blood pressure measurement. That's been known for a while. This was a case where they looked at hospitalized patients, and as soon as the doctor walked in the room, boom, the blood pressure goes up like that. And it takes a while for the blood pressure to come back down again, about 10 minutes for the patient to settle down, and we'll see that in a different context. So with all that in mind, this was sort of the paradigm, as it were, that we had been operating under for many years. Oh, this is unfortunate because all of my instructions are on here. Let's see. Well, I think I can remember most of what they are because you probably know what they are. So you want to, I had a bulleted list coming down there, but you want to have a cuff that's the right size. So the biggest problem here is the cuff that's too small, as you probably know. Nowadays we encounter a lot of obese arms. If you try to cram an obese arm into a tiny cuff, you'll overestimate the blood pressure. Too large of a cuff is less of a problem. You want to have the patient seated with their feet on the floor. That's often not the case in the rooms. They should be sitting for 5 to 10 minutes beforehand, and that turns out to be one of the most important factors in getting accurate blood pressure measurement. They should not have had coffee right before they get their blood pressure measured. So coffee drinkers do not, as a rule, have a higher incidence of hypertension, which is good news for most of us coffee drinkers, because patients actually become used to the pressor effect of caffeine relatively quickly, so they don't get sustained hypertension. But if you drink, a quad latte and then check your blood pressure 15 minutes later, it will have a pressor effect. So you want the patient not to do that, and you don't want them to have imbibed in cocaine right before they come in, ideally as well. Finally, another very important thing is the patient should take their blood pressure medication before they come to clinic and have their blood pressure checked. And a lot of patients, I don't know if you've had this experience, but I've had it many times where they come in and they say, well, I was coming in, I thought I'd get my blood checked, so I didn't take any of my medications this morning. And that obviously makes it difficult to assess the effects of the medication. So, I missed a lot of stuff here. All right, well, I'll tell you what was going to be there. Problems with the usual office blood pressure. First of all, mercury sphygmomanometers are a thing of the past. Do you guys use mercury sphygmomanometers anymore? Probably not too much. They're usually banned in most places. So we rely on the dial ones that are called aneroid sphygmomanometers. And those are generally reliable, but they do require some calibration. But the other major problems that people have discovered is that doctors and nurses as well, but doctors are perhaps even more prone to this, are a little bit sloppy in the way they take blood pressure in most cases. We tend to round off to the nearest 10, and we tend to fudge the numbers when they're close to guidelines. So what I was going to show you here is a study that was done at Hopkins by one of our fellows, and they looked at data obtained in our diabetes clinic for blood pressure. And if the data were taken appropriately, you would expect sort of a Gaussian bell-shaped curve of results. But what you saw was big spikes at every 10. So it was clear that people were rounding the numbers off to the nearest 10, which is not great. But perhaps even bigger problem was there were two very large spikes at systolic of 130 and systolic of 80. And it happened that at that time, that was the goal blood pressure for diabetics, 130/80. So it's clear the docs were rounding down to 130/80 so that they didn't have to bother intensifying treatment. We found in another study that diastolic blood pressures tended to be overestimated by manual measurements compared to oscillometric. And I think that what a lot of doctors do is they're letting the air out, and they get to maybe 70, and then let's call it 70, we're not going to bother going all the way down to 50, and they just let the air out. So these sorts of things have led to a recognition that blood pressure measured by physicians is problematic, and we should look for other technologies. Perhaps the most important technology in the measurement of blood pressure is 24-hour ambulatory blood pressure monitoring. Now, has anybody here used this on a patient? Not a soul. Okay, this is not surprising, and it's very typical. At Hopkins, I am the person who sets these things up, and I get a trickle of requests for this, but it's a tiny, tiny fraction. You may be aware of the fact that the U.S. Preventive Services Task Force has now recommended that all hypertensives get ambulatory blood pressure monitoring to confirm their diagnosis. Clearly, we're not doing that. This technology has been around. It's actually been around for about 50 years, but it's been around in almost unchanged form since the 1980s, and it's just not catching on. it uses what's called the oscillometric blood pressure technique. And this is what's used actually in all automated devices. So a Dynamap or whatever kind of automated bedside device you use, they all use oscillometric blood pressure measurement. And I think it's worth knowing how this works a little bit so that you understand its limitations. There's no measurement of sound with automated blood pressure. There's no microphone in there. So these things pick up pressure fluctuations in the cuff. And you've probably noticed when you're taking manual blood pressures that as you let the air out, the needle starts to jiggle as you get near systolic. And then as you get to diastolic, it stops jiggling. Well, what automated devices do is they measure that fluctuation in pressure. And what you see is something that looks like the bottom part here. There it is. This thing. So the oscillations increase. They reach their maximum at mean arterial pressure. They start before you reach systolic and they continue beyond diastolic. And the companies that make these will measure this envelope and then transform that into systolic and diastolic. And this technology is very well developed. Now people sometimes ask, which is more accurate, manual or oscillometric? And there really is no clear answer to that because every device uses a different proprietary algorithm made up by the manufacturer. And although there are studies comparing automated devices to manual devices, they don't yield consistent results because it varies from device to device. But in the field of hypertension, it's now accepted that oscillometric measurement is just as good, actually better than manual measurement. Better because of some of the reasons that I've alluded to about measurement technique. But it would not be correct to say that automated devices consistently overestimate systolic or underestimate systolic. People used to say things like that, but we don't feel that's true. Okay. So the advantages of ambulatory blood pressure monitoring are that the most important thing is that they predict the risk of cardiovascular events as well as measures of end organ damage like left ventricular mass or carotid intima media thickness, measures of vascular damage better than office blood pressure. So they really seem to get at the underlying concept of why we measure blood pressure. They also can identify a white coat effect. They can identify what's called masked hypertension. I don't know if you guys have heard this term, but this is starting to come into vogue a little bit. These are people who have normal office blood pressure measurements, but persistently elevated blood pressure measurements outside of the office, kind of the inverse of the white coat effect. What you do about that is being debated. And they also measure blood pressure during sleep, and that allows us to identify whether the patient's blood pressure drops during sleep, as that gentleman's did that I showed you earlier. That's called nocturnal dipping. That's a sign of healthy chronobiology. If you don't dip during sleep, you see that a lot of times in CHF patients, sometimes in patients with sleep apnea. That's considered a bad prognostic sign. Whether treating that affects outcome is still debated. Now, why hasn't this taken off? Well, the equipment's fairly costly, so each of those devices is about $2,000 or $3,000, and they break and people lose them and things like that. In our practice, I insist that people come back the next day to bring them. Lots of times people want to FedEx them back, but I find that they unfortunately disappear sometimes when that happens. There's never been great reimbursement from Medicare, and that's why a lot of private practitioners have not gotten into the act. So consequently, it's not all that widely available. Do you guys know if there is somebody here doing ABPM that you could refer to? There may not be. So I do it, and you can send people to Hopkins and get it done. But typically then you have to wait for the patient to go over there and get their blood pressure checked and come back again, and so you're not going to get quick results from that. It's a bit uncomfortable for the patient, not too bad. So these things are set to go off every 15 minutes during the day, or every 20 minutes you can set what you want, and then about every hour to half an hour overnight while they're sleeping. And surprisingly, people can usually sleep through these things. The actual blower unit, I usually have them put under the pillow to muffle the noise, but they can usually sleep pretty well. And by the time you finish it, you get about 80 readings. But again, it's inconvenient. The patient has to come down to have the monitor put on one day. They have to come back the next day to have the monitor removed. So if they're driving in from Hagerstown or something, that's a good commitment of time. And there are occasional technical malfunctions. Usually these things work, I'd say probably 95+% of the time, but sometimes the battery dies or something halfway through. So given how good ABPM is, and there's a ton of literature on it, it would be nice if we could find out some technique of getting relatively the same data without the inconvenience. So a couple of things are being looked at now. One of them is home blood pressure monitoring, and another is what's referred to as automated office blood pressure monitoring, or AOBP. Home blood pressure monitoring you're all familiar with. I don't have any stock in Omron, but they're probably the leading manufacturer of home devices and generally produce accurate machines. So I tend to tell patients to buy this brand, although there are other very good brands. Another thing you can do is look in Consumer Reports. They actually have a pretty good protocol for validating devices, and I sometimes will reprint their rating. These machines now cost about $30 to $70. There's some fancy ones with Bluetooth that go to $100, but they're pretty reasonable. So these things can be empowering. A lot of patients really get into it when they start measuring their blood pressure and they come in with spreadsheets and so forth. They're relatively expensive and easy to use nowadays. You don't have to pump them up, and you should not buy the ones where the patient has to manually pump them up, because that actually does raise blood pressure, the act of pumping. So get the totally automated ones. They're relatively convenient for the patient. They can do stuff without having to come in for an office visit. And when I'm titrating meds on difficult hypertension patients, I try whenever possible to use office readings. A lot of these patients come from the Eastern Shore or whatever, and so I'll have them check their readings at home while we're making medication changes so they don't have to come in every time for an office visit. And again, this is a better predictor of outcomes than the usual office blood pressure measurement. Disadvantages, yeah?
Is there a difference between the wrist monitors versus the arm cuff monitors?
Great. A question is whether wrist monitors and arm monitors are comparable. Theoretically, they can be. In practice, I tend to tell people to get arm monitors because wrist monitors are a little fussier. You have to hold them at the right level. And I think a smaller percentage of them have been validated. So although I wouldn't make a blanket statement that they're all no good, generally most hypertension specialists will tell a patient, use an arm monitor. Patients who are very obese and you can't get a big enough cuff, I'd probably go with a wrist monitor. There's still no clear consensus about how to use these things. You don't just want to give it to the patient because they'll take all kinds of crazy readings. Typical protocol, typically what we do with these though is we treat it sort of like ambulatory blood pressure monitoring. In other words, we'll do sort of like a series of readings for a week and take an average of that, and that'll determine whether they're under control. And then we'll kind of leave it alone for a while, and then maybe do another series somewhere down the road if we've made a medication change, or maybe just every 6 months to monitor whether they're progressing. But they don't have to continually measure their blood pressure every day, even though a lot of patients like doing that, and I don't tell them not to if they want to. The one thing I do tell patients not to do is to measure their blood pressure 6 or 7 times a day, or 10 or 12 times a day. I try to limit them to twice a day, and I also tell them, don't measure your blood pressure when you're feeling bad. So what a lot of patients will do is they'll say, gosh, I had a headache, so I checked my blood pressure, and it was high. It's difficult to know what to do with that information because you don't know what caused what. So headaches or any kind of pain or distress can make blood pressure go up rather dramatically. And we don't really treat the spikes of blood pressure. What we're trying to treat is sort of a concept of a basal resting home blood pressure. So we really don't want to measure all that variability with home blood pressure monitoring. We really just want twice a day readings. The other thing that I'll mention right now that's sort of frowned on in the hypertension community, and there really is not a lot of data on this either way, but hypertension specialists, as a rule, do not recommend PRN dosing of blood pressure medications. So a lot of docs will say, and this has a lot of physiologic plausibility, they'll say, well, check your blood pressure. If you're not feeling well, if it's above 160, take another amlodipine or another lisinopril or something like that. The reason that that's not recommended typically is because it's very hard to match the pharmacokinetics of the drug to the peak of the blood pressure. As you saw in the previous slide, the peaks come and go very quickly. You give somebody a dose of amlodipine, they're going to have that in their system for 3 days. So you'll probably not do that much to lower the peak, and you'll probably overtreat them for the following day or two. So I think you end up inducing more oscillations in their blood pressure when you try to smooth them out by doing PRN dosing. So I virtually never do PRN dosing. I think about the only time I do it is just when I've got some patient who's so insistent on doing it that the only way I can maintain any kind of relationship is to permit them to do that occasionally. But I really dissuade them from doing that. When you do this, in most of the protocols that are published, they recommend discarding the first day's reading when the patient's first kind of playing around with the machine because they tend to be high. Some people say discard the first of 2 readings as well. Many patients still can't afford these, of course. I mean, not everybody has $60 to throw at that. You still have to pay attention to technique, as I've already alluded to, particularly cuff size, and sometimes it's hard to find big cuffs in these home machines. And then again, you have to wait for results. So if you send somebody home with a machine, it may take a while to get enough data back. And not surprisingly, patients may edit their results and show you better numbers than what's really going on. So the next technology, which is sort of the newest kid on the block, or at least what's getting a lot of interest now, is what's called Automated Office Blood Pressure Measurement, or AOBP. And there's 2 devices that are most commonly used. The first one to come out is BP True, made by a Canadian company, and now Omron has a device. And this is the device that was used in the SPRINT trial, which I'll talk about later. But the way these things work, these were developed as a means to measure blood pressure in the office without the white coat effect. So they both take a series of blood pressure measurements and then average the results. With the Omron, once you hit the start button, it starts a timer that can count down anywhere from 3 to 10 minutes. You can set that. And then it takes 3 readings separated by 1 to 3 minute intervals. And it turns out it doesn't really make much difference whether you choose 1, 2, or 3 minutes. So 1 minute is actually long enough to wait. BP True takes an immediate measurement and then takes 5 more measurements at 1 to 5 minute intervals, but discards the first measurement and averages the remaining 5. In our clinic, we use the Omron 907, the one I showed you, but BP True is very widely used. And so this should be done with the patient seated alone in a quiet room with no clinicians present. So this provides a mandatory pre-measurement rest period, and I think this is one of the biggest factors in trying to get good blood pressure readings. So even if you don't adopt this technology, the one thing I would urge you to do is try to let the patient rest before you check their blood pressure, or if it gets checked right away by the CMA, recheck it yourself. Because what I see every single day in clinic is a patient who, again, runs to get to their to get to their office visit. They're stressed out, they got stuck behind somebody in the garage who's going 2 miles an hour, and then by the time they get there, their blood pressure is very high. Their sympathetic activity is up just from standing, and the moment you sit down, you still have that vasoconstriction from standing, but you've got more venous return, so you end up with an artificially high reading. So a patient might get 160 over 90, and then when I check it 20 minutes later in the clinic, it's come down by 20 or 30 or 40 points systolic. That happens like every day. This has been studied. This was one study where they looked at 55 hypertensives, and they found that there's a drop here of greater than 10 millimeters of mercury waiting 10 plus minutes, but most of the drop occurred in the first 10 minutes. So if you can wait 10 minutes before checking your blood pressure somehow, that's a good idea. So the advantages of ambulatory office blood pressure are that it correlates well with home blood pressure averages and daytime waking average from ambulatory blood pressure. When you get a 24-hour blood pressure report, you'll get typically 3 numbers. You'll get all the data, but you also get 3 numbers. You get a 24-hour average, which is usually the most important number. You get a nighttime average, and you get a daytime average. And this AOBP correlates very well with the daytime average. This eliminates the white coat effect. It's relatively easy to perform. It's a better predictor of end organ damage than usual office readings like ABPM and like home blood pressure monitoring. And it provides immediately actionable blood pressure data. So there's this phenomenon known as clinical inertia, where the patient comes in and their blood pressure is 150 over 90, but you think, gosh, I just don't feel like this is a very representative value today. They were stressed out, maybe something happened, maybe they just ate a lot of salty stuff, and so you disregard it and wait till next reading to titrate the medications up. And I think we all do it. I certainly have done that many times. People who study this have pointed out that this happens way more often than it should, and we think that some of the reason that it happens is people don't trust these readings. And the thinking is, if you could do AOBP, you'd get good quality reliable readings in the clinic that you can immediately act on and titrate the meds up. In the SPRINT trial, again, which I mentioned, they used the 907 device. Now, the disadvantage is putting somebody down on one of these things takes a little bit longer. It could take up to 20 or 25 minutes per arm, depending on how you set the intervals. So that would be 40 to 45 to 50 minutes of blood pressure measurement. Now, try doing that in a busy clinic. It does depend to a certain extent on a wait time setting, so you could set the intervals lower, like you could just have them wait 2 minutes beforehand instead of 10. And people have pointed out that this shouldn't be considered that big of a drawback because really we should be having them wait anyway. So if we're doing even regular blood pressure measurements correctly, it should be taking longer than 2 minutes to get a blood pressure. Usually this requires having an extra waiting room where you stick the patient while they're taking their blood pressure measurements, and not all clinics have that. In addition, a lot of times the medical assistants, when you set them up to do this, want to use that time to do their med rec and other stuff like that, and you really shouldn't be doing that to do this properly. The patient should be sitting quietly and not talking, and they should not be checking their email or playing Candy Crush or something like that. And in addition, this requires an investment in new equipment, and these devices are on the order of $700 or $800 a piece. So, current guidelines are now favoring ambulatory blood pressure measurement and AOBP over usual blood pressure measures. One thing I'll point out right off the bat is that manual blood pressure measurements are almost universally felt to be less desirable than automated measurements. And this is precisely the opposite of what many of us have been trained. Recheck the machine yourself when you don't believe it. And I see this in the clinic all the time too. So they'll get an automated measurement by the CMA, and then I'll recheck it myself manually in the clinic. It'll be much lower, and the patient will say, oh, there's something wrong with the machine because you checked it manually and it was much lower. And I explained to them, no, it's not the machine. It's the fact that you had a chance to wait for 20 minutes and your blood pressure came down. But for all the reasons I've said, oscillometric automated blood pressure measurements, whether they're single or multiple, whether they're in office or out offices, are now preferred to using the stethoscope. That's almost universally the case by all the hypertension societies in the US, Canada, and Europe. And now this is the other thing that I think is worth taking home out of this. So what they found is that this threshold of 140/90 that's been our typical cutoff in the clinic corresponds to about 135 for ambulatory office blood pressure measurement, home blood pressure readings, or the awake portion of a 24-hour reading. So if you're sending your patient home with a monitor and you want to know when, and let's say they don't have hypertension, you want to know at what point you're going to start treating them, you typically set the bar 5 points lower, 135/85. And you would use the same threshold if you're using ambulatory office blood pressure monitoring. If you're doing a 24-hour monitor, then you're averaging in sleep readings as well, so the 24-hour average is lower. It should be less than 130/90. So if you do send somebody for 24-hour ABPM, you'll get back a 24-hour average, and the decision cutoff, assuming you're going with a 140/90, would be adjusted to 130/90 for the 24-hour average. Any questions about that? All right, and a typical algorithm now, and a number have been proposed, but this again has not been fully standardized, is to still do office blood pressure. If it's sky high, there's no question they've got hypertension. You go ahead and treat them. If it's less than 140 by a usual office blood pressure, which tends to run high for all the reasons I've said, you can feel okay saying they're not hypertensive. Now this will miss masked hypertensive patients who have high blood pressure readings out of the office. This is not addressed in this algorithm, and it's unclear how to deal with that. But generally speaking now, the way things are moving, if you get a high to moderately high reading in the office on routine reading, you want to verify that. USPSTF says do ABPM on everybody. Some European guidelines say that too. This is a US guideline, or suggestion at least, and they suggest trying home blood pressure monitoring. And they say if the home blood pressure monitoring is high, you could say that confirms it well enough. But they still say if the home reading is okay, you should still do 24-hour ABPM. So this is a lot of home and ambulatory blood pressure monitoring. They're recommending doing this on everybody that you diagnose with hypertension. Okay, so that finishes the measurement portion of the talk. So I'm going to go quickly through the other 2/3 of the talk. I wanted to say a little bit about hypertension guidelines because these have been changing. I'll cut to the chase and say that really in the US we're kind of waiting on the successor to JNC8, which will be the American College of Cardiology, American Heart Association guidelines. That last time I talked to somebody who has some inside knowledge, said they will be coming out in the middle of 2017. They're basically finished. They're being sent out for peer review now. So just to give you a little background about JNC, this guideline process started back in the Nixon administration, not long after they did the big trials in the VA system. And at that time, most docs were not necessarily convinced that you needed to treat blood pressure, particularly mild blood pressure. So they did trials in the VA system, and then the HDFP trial, and they found that yes, you really should treat hypertension, makes a big difference. So the government tried to promulgate this information to practitioners. They set up this national hypertension program, and they started publishing these guidelines. It came out about every 5 years. JNC7, which is the one that I spent a lot of time with, was published in December 2003. And these guidelines were kind of like book chapters on hypertension. They covered a lot of ground. They had goals, but they also talked about workup and secondary hypertension. Then what happened with JNC8 was a little different. So people started to get concerned that these guidelines were too arbitrary and too influenced by various hypertension experts, many of whom were heavily subsidized by the pharmaceutical industry. So they said we need to make this process very transparent and very evidence-based. So JNC8 had much stricter criteria about the way they would make these guidelines. First of all, they only looked at large clinical trials and over 100. And then they answered just a few specific questions after doing systematic reviews. And it took forever to get JNC8 together. So it took till 2013. That's about 10 years. Sorry. And just as they were about to publish it, the NHLBI decided they really shouldn't be in this guideline business at all, and they passed it off to the American College of Cardiology. And the people who had just finished writing this said, well, we don't want to give all our work to another organization and let them fool around with it for another 5 years, so they just published it in JAMA as the JNC8 authors, or the authors formerly known as JNC8, or whatever you want to call it. So that's what we're still operating under, because no guideline in the US has since supplanted this. So as of December 2013, we have these guidelines, which you're probably familiar with. They simplify things a little bit. So moving from the older to the newer guideline, everybody is treated to 140/90, including diabetics and CKD patients. But they loosened up the guideline for people over age 60. And this was largely because they just didn't have good data on this population. So there were trials in older patients, but they didn't treat all the way down to 140/90. And this was a rather controversial guideline. Lots of people objected to this and said, this is a big mistake. You're going to end up causing a lot of strokes by not treating older patients more aggressively. So the next big thing that happened that affects the guideline process is the SPRINT trial came out, and this was a little over a year ago. The trial was halted prematurely, and it was got some popular press, and then ended up being published in New England Journal the November before last. The basic treatment idea, or basic study design, was fairly simple. This was done in community clinics across the U.S. and Puerto Rico, and as well as academic institutions. And they took patients that increased cardiovascular risk, but they excluded diabetics because they had already been looked at in a different study, the ACCORD study. And they randomly assigned them to a goal of 120 or a goal of 140 systolic. This was not blinded. People knew what their goals were. And they were given a fair amount of leeway as to how to get there. They had a large number of patients. You had to have some cardiovascular risk. And they, as I said, they excluded diabetes, stroke, and polycystic kidney disease. Secondary causes, severe hypertension. So they wanted people who didn't have really advanced end organ damage that you wouldn't be able to treat, but they wanted people who clearly were at high risk. And they ended up with people who were fairly, on the older side, a good fraction were above 75. Their Framingham risk was rather high, 20%. Their mean blood pressure at entry was about 140/78. These were not untreated hypertensives, but they were mostly people on blood pressure medication at the start of the trial. Almost all of them were on blood pressure, most of them on 2 meds or so. So what they did was they just said you can use any antihypertensive drug you want, but they did make some recommendations. And I'll touch on this later, hopefully if I have time, but they recommended chlorthalidone as a diuretic, amlodipine as the calcium channel blocker. They used this new ARB, azilsartan, in combination with chlorthalidone or by itself, that was given free of charge. And they had sort of a forced titration algorithm every 6 months. And the people in the lesser treated group actually were down titrated, and this was a little controversial, but they told them you have to stop drugs if your blood pressure is lower than that because they wanted to get a spread. Interestingly, at the end of all this, they found that there's an average of 3 drugs to get to systolic of 120 and 2 drugs in the standard arm. That's pretty good, in my opinion, to get patients to a systolic of 120 average with just 3 drugs in this high-risk population. And again, they used the Amron 907 average of 3 measurements after a 5-minute rest period separated by 1 minute. They had a good spread in blood pressure control, as you can see. And the primary outcome was a bunch of vascular stuff and death. And they saw a pretty substantial difference in the survival curves between the intensive group and the standard group, as well as in death. And then in the particular outcomes, I just want to point out a couple things. The 30% reduction in GFR, the relative risk here was, or hazard ratio was 3.5. So there was it was much more common to see a bump in the creatinine in the aggressively treated group, but you did not see a 50% reduction in GFR, and you did not see people progressing to dialysis, and you did not see new albuminuria. So the thinking was, the decline in renal function with aggressive treatment was physiologic. You know, if you lower blood pressure, the kidney doesn't get as much blood. If you put people on ACEs and ARBs, the creatinine will typically bump somewhat, but it didn't cause long-lasting kidney damage. In fact, it may have even been protective. Some of this data will continue to come out. But you definitely saw a bump in creatinine, so you should expect that when you try to get to these aggressive goals. And another thing that was weird here was they did not see a benefit for stroke. And stroke is almost always the most sensitive outcome in blood pressure trials. Adverse effects, there were more of them in the aggressively treated group, not surprisingly, but no increase in bradycardia or falls. Orthostatic hypotension less common, dropout rates similar in both groups. So it wasn't dramatically worse in the tightly treated group. The other trial I want to touch on again very briefly is the HOPE-3 trial. This came out also in the last year, and this was a different sort of trial. So instead of looking at high-risk patients, they looked at pretty low-risk patients, relatively low risk. And they just took people whose blood pressure was pretty well controlled, and about a fifth of them were on meds. And they just gave everybody the same dose of an ARB HCTZ combo. So this is kind of the concept that's sometimes been called the poly pill, that maybe we should just give everybody a statin and a blood pressure pill and lower the population's risk that way rather than fiddling around with numbers and goals and everything like that. And they saw a significant drop in blood pressure. And if you look at these curves, you can see that the treated group is always lower than the untreated group, but it was never statistically significant. So this did not really make the case very well that this idea is highly effective at preventing morbidity and mortality. They did find that among the people who had the highest blood pressure to start here, they did see a significant effect. So among their most hypertensive patients, taking the drug helped, and that was not surprising. So what does this do to guidelines? Okay, as I mentioned, the ACC/AHA guidelines are likely to come out in mid-2017. Canadian guidelines have come out post-SPRINT, and they have made some interesting recommendations. So they say for ages 80 and over, diagnose at 160/90, but treat down to 150/90. For diabetics, diagnose and treat to 130/80. Everyone else 140/90. But then they say that in selected patients, and they're not that clear about who this is, but people at higher risk, you can treat them down to 120 systolic. They're not saying everybody with these characteristics should be treated to 120. But if you think you can safely do it, consider doing that. And it's a little weird because they say age greater than 75 years, treat to 120, but then they say, age is 80 and over, treat to 160. So I think the idea there was if you have an elderly person that you think can tolerate a pressure of 120, go for it. Just this week in Annals, out came this paper from the ACP and the AAFP looking at treatment in people over 60, and they've still recommended treating to a systolic of 150, but consider a systolic of 140 for high-risk patients. They did not recommend going all the way down to 120. So, when Sprint came out, there was a little bit of a panic because a lot of clinicians thought, oh my God, we're going to be expected to treat everyone to 120. I don't think that's what's going to happen. I don't know exactly what the ACC recommendations will be, but it's unlikely that they're going to recommend treating a large group of the population down to 120. They'll probably do some sort of individualized risk analysis, kind of like with the cholesterol guidelines, and then recommend treatment more aggressively for those patients. All right, any questions about guidelines? So the last couple of slides I have, I just want to touch on a few things about treating resistant hypertension. So what I do in my hypertension clinic is I get patients who clinicians are usually frustrated with for one reason or another. They're on a gazillion meds, they can't get them under control. That's one class of people. You would think in a secondary hypertension referral clinic you'd see lots of secondary hypertension, but I see almost none of that. So I never see PHOs. I see some hyperaldosteronism, occasionally renal artery stenosis, but what I see tons of are patients on a lot of drugs that are not controlled, or patients who can't seem to take any drugs because they have adverse reactions to every single drug known to man. So some recommendations about things you can try with some of these patients that I do. I'll go through the lifestyle factors, using combination drug therapy, fixing the diuretic regimen, using spironolactone and doxazosin, and then dealing with side effects. So lifestyle modification, boring topic for many of us, but because it's frustrating perhaps. But I think we do need to continue to do this, and a lot of people give up on this once the patient is on several blood pressure medications. But the fact is that a lot of blood pressure medications are sensitive, particularly to sodium intake. So you don't want to stop trying to address these things just because they're on 2 or 3 drugs. I don't usually strictly put them on a 2 gram or 2.4 gram sodium diet. I haven't had that much success with that, but I do tell them to try to watch what they eat and look for the real bad actors and eliminate them. And patients, what will they always say? They'll say, I never put salt on my food. Well, I was reminded of the fact that what matters is the food, the salt that's cooked into food. And in December, I happened to be eating at Chili's with my family, and you got to give them kudos for putting their nutritional information. The Choose Any 3 Meat Special has a sodium content of 4,980 milligrams to 7,590 milligrams. So this is almost 8 grams of sodium in one meal. This will completely annihilate the effect of a diuretic if you eat this meal. And you can imagine that if you added chips and chili, you could get up to like 10 grams of sodium by the time you walk out the door. So patients need to be aware of the fact that some foods are just so heavily salted that they will have a serious impact on their blood pressure control. I wanted to try to discourage people from using super high doses of blood pressure medications. And at Hopkins, for some reason, the house staff and to a certain extent the faculty are very enamored of using enormous doses of nifedipine. The usual max of nifedipine is like 120 milligrams. And I've seen people on 180, 240, 360 milligrams, and you're really not getting much benefit from these crazy high doses. The dose response curves of almost all the blood pressure drugs are quite flat at the upper end. There may be occasional patients who, for unexplained genetic reasons, might need higher doses, but I wouldn't count on that being true. So I usually stop at about half maximal. Like with lisinopril, I don't usually go above 20. Sometimes I'll go to 40. But most of your action comes up getting up to half maximal. What you should do then is add a second drug, and in this study they showed that adding a second drug lowers blood pressure 5 times more effectively than doubling the dose of a single drug. And they looked at adding a drug from another class, starting with thiazides, beta blockers, ACEs, calcium channel blockers, and in all classes. And what they saw in the end here is that the effect of doubling the drug again was down here, and the effect of adding the second drug produced a much, much more robust effect. When you use combinations, you want to use effective combinations, and you might want to remember the mnemonic ABCD. AB standing for ACE inhibitors, ARBs, beta blockers, / CD, calcium channel blockers, diuretics. Without going into too much detail, calcium channel blockers and diuretics work well on people who are salt sensitive, and they tend to have low renin levels. ACE inhibitors and beta blockers tend to work better on people who have higher sympathetic drive and higher renin levels. When you mix these drugs, it's good to match AB drugs with CD drugs if you want a good antihypertensive effect. And the pharmaceutical companies know this, which is why they usually pair them this way. Diuretic plus an ACE or ARB, CCB plus an ACE or ARB. You don't see diuretic CCB combos. And another thing that's helpful here is that some of the side effects of drugs can be mitigated. So like diuretics tend to lower potassium, but ACEs and ARBs tend to raise it, so you can often avoid the hypokalemia. Calcium channel blockers make your legs swell up if you push the dose up. You may or may not know this, but ACEs and ARBs mitigate that effect quite effectively, so you can often solve that problem. Obviously, you can mix a potassium-sparing diuretic with a potassium-wasting diuretic. And here's a tidbit that most people don't appreciate. I learned this from a paper from a guy up at Cornell. But if you combine separate alpha and beta blockade, you get a better antihypertensive effect than using labetalol. And lots of resistant hypertension patients come in on labetalol because they were in the unit and they got labetalol. The thing about labetalol is to get up to 2,400 milligrams, which is the max dose, you've got to give them 6 pills a day. And labetalol is not that great of an alpha blocker. So if instead you use a separate alpha blocker, doxazosin, plus a beta blocker like bisoprolol or nebivolol or metoprolol, you'll get a greater antihypertensive effect with far fewer pills, 2 pills instead of like 6 pills. And you should not combine ACEs and ARBs. That's been looked at extensively. It's not a good idea. It doesn't lower blood pressure very well, and it causes more adverse effects. And you should not mix either of these with aliskiren, the renin blocker that doesn't get used all that much. I would urge you to try using chlorthalidone instead of hydrochlorothiazide. Chlorthalidone is underutilized, but it's known to be better in the sense it has a much longer duration of action. So the thing about diuretics is, for a diuretic to work, you need a sustained relative hypovolemia. So if a patient takes a short-acting diuretic like furosemide, and I'm going to repeat this on a later slide, they'll pee out and they'll be hypovolemic in the morning. The rest of the day, their kidneys will be in rebound mode and they'll be sucking up salt. And if they then go to Chili's in the evening, they'll take all the salt that they lost in the morning back and more, and they'll lose their relative hypovolemia. So to get a sustained hypovolemia and a good antihypertensive effect, you need a diuretic that's active relatively across the 24-hour period. Chlorthalidone definitely fits that bill. HCTZ wears off after about 18 hours or so. Chlorthalidone is twice as potent as HCTZ. That doesn't really matter, but you do need to adjust the dose accordingly. And all the big clinical trials that are NIH-sponsored, like all used chlorthalidone for that reason. Avoid once daily furosemide for the reason that I said. I just explained this. So I see a lot of patients in the hypertension clinic who come in on once daily furosemide, and there's no clear reason why they're on furosemide. They don't have advanced CKD, they don't have CHF. Sometimes they're on it because they have lymphedema of the legs, and somebody's trying to help them out by giving them a Lasix to treat the lymphedema. It doesn't work. You can't treat lymphedema effectively with a diuretic. That's a mechanical problem. It needs to be treated with a mechanical solution. So compression stockings, lymphedema physical therapy. Now patients with lymphedema who are on Lasix, if they stop it, they will get a rebound worsening, but it will not solve that problem. So try to keep them on a thiazide as long as you can, which typically would be down to a creatinine clearance of around 30. And then if you need to switch to a loop, either because they have CKD or CHF, I use torsemide almost all the time in preference to furosemide because this has a longer duration of action. It's generic, it's not expensive, it's widely used in Europe, it's got very predictable metabolism, and it's a good drug that I think is unfortunately really underutilized. If you do use furosemide, you have to try to dose it twice daily, but patients don't like to take an evening dose of furosemide. if you're going to add a fourth drug after an ACE and ARB plus a CCB plus a diuretic, it turns out the best, the most effective drug to go to next is spironolactone. And this was looked at in the Pathway 2 trial. So there they said, what should be our next drug? We know that beta blockers have sort of fallen out of first line status. But after you've got the ACE, calcium channel blocker diuretic on board, then where do you turn to? And they compared a beta blocker to an alpha blocker to spironolactone, and spironolactone won handily in terms of blood pressure lowering effectiveness. But don't neglect doxazosin or alpha blockers. So I think sort of an unfortunate consequence of our focus on clinical trials is that sometimes we overstate their generalizability and importance. And AllHat, that came out about 10 years ago or so, compared an alpha blocker to a calcium channel blocker diuretic and ACE inhibitor, and the alpha blocker arm was stopped early. And at that point, people kind of just moved away from alpha blockers totally. They didn't want to use them for anything. But there's really no data suggesting that alpha blockers as add-on drugs are problematic. So I think you really should consider using them as your fourth drug. And I almost never use hydralazine or clonidine because to me, hydralazine, you've got to dose it multiple times. You can get that lupus-like syndrome. You usually get a tachycardia. Clonidine's got a lot of problems, a lot of side effects. If you miss a dose of the pill, you get a big rebound, multiple daily dosing. Some people will sell it on the street, as you know, for opiate addiction. So I try to get everybody off clonidine and hydralazine, and I turn to alpha blockers, beta blockers, and spironolactone as my add-on drugs. And then finally, last slide, try to work through side effects. So a lot of times the reasons patients are uncontrolled is because they come to you and they say, my blood pressure is uncontrolled, but just look at my allergy list and there's 15 drugs in there. But when you go through it, it turns out that a lot of those drugs are not allergies. Maybe most of them are not true allergies. There's some kind of adverse reaction. And sometimes they're really not that big a deal. Like maybe somebody was put on a big whopping dose of amlodipine and got some leg swelling from that. Well, you can often manage that. Just use a lower dose and pair it with an ACE or ARB or a diuretic, and you can mitigate that effect if you can convince the patient to try it again. Or a patient's got gout and they've been told you can never take a thiazide diuretic. Well, you can take a thiazide as long as you pair it with something that lowers uric acid, either allopurinol, or you may or may not know this, but losartan actually has a uric acid lowering effect. It's the only ARB that has that property. I'm not sure why. But so in my patients with gout, I'll often use losartan. So use combinations of drugs to counteract these adverse effects. Use low dose combinations in preference to cranking the dose up because, again, as you get to the top of the dose response range, the side effects really blossom. And if they're allergic to everything, then you have to consider psychological issues and secondary gain. And often you have to do a lot of hand-holding here. But in the end, a lot of these patients who are viewed as hopeless causes because they can't take anything really can be controlled with those rules. All right, thanks for your patience, and I apologize for running late.